Inaba?
Paul Stoffel is the first speaker, sir.
Oh, yeah, I know. So he started us talking on the FNS system.
Yes.
Yeah, good. Carl, good to see you. It's nice. I just heard that the safest place to be now in this time of COVID is Switzerland.
Who told you that?
It's in our papers. And the worst place is to be in India. So we are on two opposite sides.
I think from the newspapers, I think the worst place probably is United States. I think they're still doing very badly. And Switzerland is always a beautiful place, even with Corona. So
I agree with that. I agree. I was in Basel last year for the AO Spine Trustees meeting.
okay, yep.
Yeah, nice.
So why didn't you give me a call? We could have gone for lunch. So the next time you're coming back.
Yeah, I just arrived a couple of hours before the meeting and left 2 hours before the meeting started.
Okay.
Yeah,
I understand.
next time, always.
Sir, sorry to interrupt you. It's only 2:30, so we go live. Are you agree?
Yes.
Okay, so within 10 seconds we will live.
Yeah.
3, 2, 1. So we are live now. We can start our session. Over to you, sir.
Okay. Good afternoon to everybody and welcome to all of you. Good morning to Carl. So welcome to the second symposium of the Ganga Hospital, and today we have chosen a very important topic: problems of the proximal femur fractures. I mean, this is something that can go very well or can go wrong and trouble the patient quite considerably. So we have the entire Ganga trauma team as the faculty, along with Dr. Danshay Raja, who is going to talk about THR in femoral neck and trochanteric fractures. But the star in the faculty today, I always call Carl as the pole star. So Carl is here joining us from Basel. Carl, thank you very much. As all of you know, Professor Carl Stoffel is from Basel. He is the primary lead surgeon for the hip unit there, and he is a specialist not only in trauma but also in minimally invasive primary arthroplasties. He's also a specialist in osteotomies around the hip joint, and it is really good and honor for us to have Carl with you us. Thank you, Carl, for being with us. And without much ado, I would hand over to Carl, who will be our opening batsman, and he will talk to us on a FNS system for the proximal femur fractures. Thank you, Carl, and over to you. Carl, you have to unmute yourself.
Okay, now it's working. So, Rajan, thank you very much for the lovely and kind introduction. And it is a pleasure for me to talk about the FNS. So the FNS is a new implant which is on the market since 2017. So first of all, I would like to start with this case. It's a neck of femur fracture. The patient is 58 years of age, male. He had a bike accident, no previous hip pain. So what would you do? Would you go for an arthroplasty, maybe 2 or 3 cannulated screws? Would you go for a sliding hip screw, or maybe something else? So the question is, why do we need a new approach to effectively treat those fractures? Simple, because with our decision-making process in our traditional implants, we're missing the mark. We've seen all those complications. I think everybody had those. And if you look at the Norwegian fracture registry from 2 years ago, they had more than 100,000 patients included in their registry. And what they reported after 1 year, still nearly 60% have got pain and problems when walking, and 60% have got some residual pain. And if you look at the survival rate, 1/3 of all the neck of femur fractures, they fail within 3 years. So that cannot be the solution what we've got. What we know, if you have got a Powell's type 1 fracture, most of us until today, we use screws. We know the biomechanical 3 screws are superior than 2. There is no evidence that 3 screws clinical are better than 2. If you use 3 screws and the apex should be distal, and the position of the screw, that's the most important point. Because if you've got a Pohl's type 1 fracture, the screw should be on the AP very close to the medial calcar, because if you place a screw somewhere in the middle of the neck, the whole neck can collapse into varus, and you've got something what you didn't want. And on the lateral view, we want to have the second screw very close to the posterior cortex. So that's all fine. The problem what we've got with type 2 and type 3 fractures, where we're missing this middle hinge. And what happens in those cases, the head will collapse into varus because we don't have enough medial support. That's a case with myself. You see that's a Pohl's type 3 fracture, fixed with 2 screws. You can see where the hinge is, and you can see everything just collapsed down until the hinge supported then the head. But that was an unacceptable result. So screws have got a high failure rate in the literature. So what we need to do is, if you have got no medial hinge, we have to shift the medial hinge from medially to laterally. So we need an angular stable implant on the lateral side to restore the medial hinge. But that's a clinical case. I fixed with the DHS with an anti-rotation screw. But this concept has got some concerns. Intraoperatively, technically demanded because you need the DHS and a cannulated screw. You've got a large surgical footprint. You've got a lateral protrusion with maybe some irritation of soft tissue. And one major problem is if you've got 2 implants in the head, you increase the tip apex distance, and that is prone for failure. Second thing is those 2 implants, they're not connected to each other. So they fail completely independently, and they don't support each other. That's a failure mechanism. Sometimes, especially in Asian population, the neck is too narrow to place 2 implants into the neck. You don't have a controlled impaction. Even if you use a fully threaded screw, you can't really resist this impaction in elderly patient. This patient, loss of offset, loss of leg length, so that's a bad result. And that's a very important factor. By inserting the DHS screw, even if you put into K-wires in, you lose the reduction. And that has been published last year in the JOT, where the author said, it's the author's experience that despite abundant provisional fixation, the sliding hip screw has got a strong rotational force on the head segment and often causing malreduction. And together with the malreduction goes the blood supply disturbance. So that's a risk for an AVN if you rotate the head. And that has been published in the Lancet 3 years ago, where the sliding hip screw has got a higher rate of AVN than cannulated screws. So all those 8 points are disadvantages of the DHS with an anti-rotation screw. So the dilemma is, on one side, we want to allow some fracture impaction, but on the other side, we want to avoid an over-shortening, and we want to avoid a varus collapse. So what can we do? And I think the solution, what we've got at this stage, it is from Osteosynthesis, called the femoral neck system, the FNS. The FNS we launched in 2017. Meanwhile, there are more than 18,000 implants implanted, and the failure rate so far, what we know, is reported less than 6%. And I would like to show you that with the FNS, you will overcome, or you can overcome all those complications. It's simple, easy, and straightforward. You've got a small footprint, only 1/3 of a DHS with an anti-rotation screw. You don't have lateral protrusion because there is a maximum of a sliding distance of 20 millimeters. There's no lateral protrusion. You can place the whole implant in the central position, so that means you decrease the TAD. You've got a connection between the anti-rotation screw and the main implant. So the screw and the ball, they work together, and even the screw is taking probably 20% of the actual load. You can control the impaction, so you can tell the system how much collapse do you want. You want the whole 20 millimeters or maybe only 5 millimeters. So it's up to you to decide how much of impaction do you want. And I think the most important thing is you just slide it in the main ball, not the anti-rotation screw, but the main ball, so you don't have this huge torque that you lose the reduction or AVN. The system has been designed by from the AO LEG, the Lower Extremity Expert Group, in collaboration with Synthes. It consists of the plate, of bolt, which can slide in the plate up and down, of an anti-rotation screw, and of a locking screw in the shaft. The plate itself is only minimal. It comes in a 1 or 2 hole plate. It's the same for the right and the left side. The angle between the bolt and the lateral plate is 130 degrees and has got a hole for a 5-hole locking screw. And that's for the angular stability. If you have got a varus configuration, all what you have to do, you put the whole system slightly more in varus, or if you've got the valgus, more than slightly valgus. But the angle between the barrel and the lateral plate remains always the same. Here you've got the 3 versions. And then you've got the bolt. The bolt is the main load carrier. It has got a blunt tip. It has got the dynamic design, so it can slide laterally, maximum 20 millimeters. You can insert it smoothly, so no torque. And it is designed that you don't have a lateral protrusion. The anti-rotation screw provides a rotational stability. It has got also a blunt tip, and it's locked at the base with the bolt itself. So the instruments, and that's a beautiful thing. You've got one main insertion handle. The insertion handle is to insert the bolt and the plate, and allows for the rest instruments to be added on, like the insert. Over the insert, you drill and insert the anti-rotation screw. Protection sleeve, you drill and insert the locking screw. So the indicator at this stage is for neck or femur fracture, and not really for poor or subtrochanteric fractures. But I have to tell you, we had a few cases where we've got stable poor trochanteric fractures where we use this system as well. But obviously, it's not indicated to use for poor trochanteric fractures. The surgical technique, it's easy because it's repeatable. All what you have to do, you have to place a central K-wire in a central position, and from there onwards, everything is guided on. So you can reduce the amount of instruments in the surgical steps by more than 50% in comparison with a DHS. That's just a short animation video. First, reduce the fracture close, then you temporarily fix it with a K-wire, or maybe even 2 if the bone quality is not too good. Then you make the lateral incision of maybe 5 or 6 centimeters. You split the whole soft tissue. You've got the guide, and then you insert the guide wire in a central position. Then you measure the length of the whole K-wire, of the wire, and then you use the 3-step reamer, what you used with the DHS, all the way down. Then you remove the reamer, and then you insert the bolt with the plate with the main handle. The next step is you drill for the anti-rotation screw, which is exactly the same length as the bolt what you measured before. You insert the anti-rotation screw, and you have to use a torque wrench to lock the anti-rotation to the bolt. Then you insert the sleeve, you drill for the sleeve, you insert the locking screw into the shaft, also with a torque method. At the end, you can apply interfragmentary compression. You can use a multifunction rod through the sleeve first, and then you connect this multifunction rod with the anti-rotation screw. And by pulling it backwards, you can achieve interfragmentary compression at this level. Once you're happy, you remove the multifunction rod, you remove the sleeve, you remove the handle, and the surgery is done. You will see if you're not too left-handed, it takes you probably 14 to 16 minutes to do the surgery. A few technical tips if you do it the first time. Make sure that the K-wire is really positioned more or less in the central position, and just end up sub-control, because it's important that you have got the full length of the implant. Then the next thing is come a little bit, you see the entry point, the entry point here is slightly posterior because you want to be in the axis of the neck into the head. So not pure laterally, maybe 10 degrees or 15 degrees more posteriorly. There's the entry point. So let's continue. So that's entry point, and then you insert the first K-wire. And there's a device which allows you to change over the first K-wire if you're not happy with the position, that you can change either the entry point or the angulation, because we know so often you try and 5 or 10 times, you have to change the direction, you're not really happy. So in this case, you can see and this is the correction device. You can see on one row, you can change it 5 degrees either anteriorly, posteriorly, superior, inferiorly. And in the second row, you can change the entry point for 5 millimeters. And that's what I'm doing here. You can see I'm slightly too anteriorly. So what I do on the AP view, I'm more or less perfect. So I'm more or less in axis and where I want to be. So AP is fine, but I'm too anteriorly. So what I can use now, this device, so I change I want to leave the entry point. So therefore, I have to first fix the device with a second K-wire to the lateral cortex, and then I can change the direction. So first fix the correction device to the bone with second K-wire. Then you can take out the first K-wire. So that's maybe something what you have to do a little bit before you go into the theater. Just look at the device and play a little bit around, because it's really helpful that you can change then the entry point. Then you take the first K-wire out, and then you change the direction. So you want to leave the same entry point. Now you can see on the different view, the entry point remains the same with this technique. You see the entry point is the same, but you're going into different direction. And now I insert now the K-wire again. And I say again, you can, if you're really familiar with this device, you can go all around 360 degrees. Oh, sorry, you just wanted to see the final result. And here you can see how I corrected the new position, which is better than it was previously. The second thing is the 3-step reamer. So initially we didn't really take care of, but really go and ream all the way down, because otherwise the plate stays off a little bit the lateral cortex. It's not a problem until it's less than 2 millimeters, but if it's more, it can be a problem. So ream all the way as shown here, and then the plate really sits on. That's an important bit here. That's an important bit here. You see, I want to show you what we changed in the surgical technique, and I think you will have to, I don't know if you get the new version. So the first version was that you insert first the anti-rotation screw in the head, and then you lock the plate to the shaft. But we changed it now, because what we realized, if the plate is not perfectly aligned laterally, and you've got already the anti-rotation screw in the head, and you want to turn the plate that it sits perfectly laterally, you twist the head. So it happens the same. So it happens the same thing with the DHS. So you see, the plate is not perfectly aligned laterally. So if you try to change this position, you can see what happens with the head. You twist the whole head around, and that happens with the DHS. So first of all, you lose the reduction, and you stretch all the important vessels coming from the back into the femoral head. So that's why we advise that you first fix the plate to the shaft, and then you insert the anti-rotation screw. So in the new surgical technique, that's changed. Okay. Regarding the compression, you maybe don't know how the compression works. So the anti-rotation screw has got a thread at the end. You insert it, and this multifunction rod goes into the end of the blue of the anti-rotation screw. And since the bolt and the anti-rotation screw is one unit, you can pull everything backwards. So you see, as soon as you tighten then the black knot, you will pull the head and the bolt backwards. That's it. Okay, that's how the compression knot works. How can you achieve a limited impaction? So if you measure 75, then you use a bolt of the same length, and that gives you a collapse of 20 millimeters. But let's say if you've got a small patient and you measure only 70 millimeters, but you have to use the shortest bolt of 75. That means the collapse is now reduced by 5 millimeters. So you don't have the 20 millimeter of collapse, so only 15 millimeters. So that's how it works. The important thing is, if you measure 70, you have to ream for 70 and don't ream for 75, even if the bolt is 75. But you already have got a pre-collapse of 5 millimeters. And 5 millimeters is the same as the distance of the depth gauge itself. So if you have got 95 measured, 95 implant, that's how it looks like. If you measure 95, if you use a 100 millimeter implant, you already have got a pre-collapse of 5 millimeters, so the total collapse of you've got is only 15. If you measure 95 and you've got a huge gap, and you use a 95, then it can collapse all the way down to the 20 millimeters. But if you measure 95 and use, let's say, if you only use a little bit longer, 5 millimeters longer, so that's how you can reduce the collapse. So in worst case, what you can do, you can even measure 95 and you use a 150 long bolt. That means you don't have a collapse at all. But that's risky because you want to have some bone compaction and impaction for the fracture healing. Biomechanically, we have shown that the DHS screw and the blade and the FNS, they behave all the same. So the FNS is not superior than the DHS with an anti-rotation screw, but hasn't got all those disadvantages and is significantly better than 3 cannulated screws. Regarding the torsion, that's what you measured. I think the longer the implant is, the more distance you've got between the anti-rotation screw and the ball, more resistance you've got to limit the torque. The longer the implant, the more resistance torque have you. And that's a big benefit comparing to a DHS plate, because a DHS plate has got the same resistance torque even if you go for a longer implant itself. So clinically, there are a few single cases. We have got one big series of 125 patients. We had mainly elderly patients, more than 70 years of age, and mainly females. And so far, the complication rate was only 3 out of the 125 cases. Some indications, you see that's an elderly lady, a Garden 1, Poles 2 type fracture. In the elderly patients, we leave the valgus impacted fracture as it is, and we just check the correct the retroversion. FNS is in. You can argue in the early days we were always a little bit too inferiorly. Nowadays we would like to have more central center. That's after surgery, after 6 weeks, after 6 months, you see the fracture healed in the same position with no secondary loss. The second hint is if you've got a case like this here, you can see it's a Garden 2 fracture. The middle wall is the middle hinge is not intact anymore. Don't reduce a displaced fracture in elderly lady. What I try to do here, because they will fail and they will end up with an arthroplasty. Another thing, if you've got a patient with a commuted fracture, a young patient, I tend to put the head slightly in valgus because that gives you a little bit more stability. And you can see the fracture has healed after 6 weeks, after 3 months with no secondary problem. If you've got a young patient, and if you have got somewhere a reference, here you can see close reduction. You've got a loss of this middle hinge, and here you've got an additional an anterior small fragment. So in younger patient with a simple fracture with insufficient close reduction, don't hesitate to do an open secondary approach. That's what we did in this case, an anterior approach, reduce the open, fixed it, then with the FNS, and even fix this small fragment back, and that's the intraoperative situs. X-ray after the surgery, after 6 weeks, partial weight bearing, and after 10 weeks, nearly healed. And that's this young chap after 10 weeks. Of course, he's a little bit limping, but he's walking without the crutches. Another patient here, he had several fractures. I just focus here on this fragment here. You see a big fragment pulled out of the middle calcar. That's the situation of the close reduction. Can't leave it as it is. So we did open reduction and open tutor approach. And then that's how it looks like. Here, after a certain time, the fracture is now progressing slowly. After half a year, that's the situation. So you see immediately, you still see the gap, but the patient is walking. So walk, walk, walk. So the patient is walking after nearly 9 months, so not too bad. And here you can see his X-ray after 1 year, and finally, or even the middle calcar fully healed with this system without a loss of reduction. So back to this case here. So what would you do? I think if you look at the screws, and that's a publication from Lundquist, as soon as one of the screws is not perfectly positioned, you've got a non-union rate of 40%. If both screws are somewhere in the middle, you've got a 100% non-union rate. And that's another publication. We just published it last month, where we measured the distance between the inferior screw and the calcar. And the thing is, as soon as you use a screw, the further the distance is, the less cycles to failure you need for failure. So if you go back to this publication, they used 95% in Norwegian screws. So I think failure is mainly because surgeons are still using screws to fix femur fractures. So in our clinic, we got rid of cannulated screws, even for Poles type 1 fracture. With the sliding hip screw, we know all those disadvantages. So sliding hip screw is not. The patient didn't have any symptoms, so no total hip arthroplasty. So we did the FNS, that's the X-ray after the surgery, and here after 6 months, you see the fracture had healed completely nicely. So I run a little bit over. I'm really sorry for that, but hopefully I could give you a little bit an insight, some rationale of the benefit of using the FNS for neck of femur fractures. Thank you very much.
Thank you, Carl. It was very nice. So my question is like, now that you have said FNS is good, see, like actually, it is a shorter, or like the side plate of the DHS has become smaller, and then the derotation screw that we used to use along with the DHS is now getting combined as a single unit.
That's correct.
So,
And but
and
you have got sorry.
And also because earlier there was collapse that was happening in the post-operative period. Now we are not allowing that to happen. Is that correct?
You're not. So what was the last question? You're not.
The continuous collapse that used to happen in a DHS before.
It's not happening anymore. So the maximum is 20.
We are maintaining the length.
That's right. That's right. That's right. And it's up to you. How much of collapse do you want? Do you want to have all the 20, or do you want to have maybe only 5 millimeters? So normally what we do is in elderly patients with a stable valgus impacted fracture, or even a Garden 1, Garden 2, we allow the full collapse because they're primary stable. Only in younger, and they're allowed to full weight bear from day 1 onward. So every elderly Garden 1 or 2 fractures, they're allowed to full weight bear. In the younger patients who can partial weight bear, and it's very much important that you keep the length. We limit the amount of collapse of maybe 10 to maximum 50 millimeters, and they need to partial weight bear for 6 to 8 weeks. But yes, you're right. Those are the 3 main differences.
So how do you decide the amount of collapse? Because during surgery, we know that we can nicely reduce it. Once the cost reduction is done, we know it is reduced well. How do we know whether to compress 5 millimeters or 10 millimeters?
I think that's a tricky question. You see, initially, we only came up with this idea of this pre-collapse for cases where the neck was very short. So I think it's a little bit dangerous if you limit the amount of collapse only to 5 millimeters. So the decision how much you want to collapse is a little bit up to the surgeon. Normally we say we don't recommend more than 10 millimeters of collapse, because if you could collapse of maybe 15 to 20 millimeters, I think the patient, even if the fracture heals, has not got a good result. So if you think the shortening is too much, then you might reduce it. But I think that's a good question. You have got no clear answer. How do you decide preoperatively? How much of collapse do you allow? It's hard to say. So I think in younger patients, you accept a little bit less collapse than in elderly patients. But I think you have to make your experience how much of collapse do you allow.
Okay. Any questions from others, or any of you have any question? Please ask. Well,
in case of gap over the medial calcar region, and if you don't allow it to collapse, also there can be chance of non-union, and it can ultimately result in an implant failure. Do you bone graft in such cases?
Primarily not, no. So I don't do any primary bone grafting if there's a defect medial in the calcar now. And secondarily, it depends on manufacturers. How old is the patient? How good is the bone stock? But primarily, we don't bone graft a defect medial in the calcar. As you've seen in the last case, which I've shown you here, even if there was the defect medially, see, after half a year, you still see the defect medially. Huh? And then only after 1 year, suddenly, it completely filled up with new bone. So no, we don't fill gaps medially.
Carl, in this patient, you can see that the screw is almost nearly probably 3 or 4 millimeters in the subchondral area.
Yep.
So how far to go in, or how far you have to stop short? Is it the Baumgartner's rule? Does it hold good in this also?
So that's a good question. So at this stage, we don't have any values to know if the Baumgartner rules apply to the FNS system as well. What we found is a little bit, because the longer the implant is, the more divergent the 2 implants are. The more divergent is, the more distance is between the tip of the anterotation screw and the ball. So that gives you more patient stability. So normally we would like to go as big as long as you can. So go really subchondrally if you can, and don't make it too short. I think that's also the reason why the anti-rotation screw is a little bit shorter than the board. But if you measure 95, they come in one package. You have no other choice than to insert also the same length of the anti-rotation screw. But yes, go as close as you can to the subcondylar area. I think here you couldn't go another 5 millimeters. I think that would have been too much. But yes, go as close as you can.
Even in this patient, though there is not much of neck length collapse, we see the trochanteric tip is not in line with the center of the head. So there should be some amount of change in angle, then only then it can unite in this fashion.
Yeah, you can see.
Is there a functional Cox of error because of articulotrochanteric distance, reduction in articulotrochanteric distance?
Yeah, so I don't have a full pelvis, so I don't really know if he has got on the other side, not on this X-ray, if he has got on the other side the Cox of error as well, because he's, as you said, the tip of the G-tip is above the center of the head of the head. But if you want to see how much collapse he had, so if you look at this line here, that's the anti-rotation screw at the end. So when we started, normally this here is in line with this line as well. So you can see the collapse of this patient was from here to here. This is the whole distance. So that's how much it can travel. As soon as the anti-rotation screw hits here, this part of the plate, then it stops. So I would probably say if the whole distance is 20 millimeter, here we probably have had 7 millimeter of collapse. But I think it's you see the literature is very different how much they allow to have collapse. Some say more than 15 is not good. Some papers say you can go up to 20 millimeter of shortening. I think in a young patient, 20 millimeters is too much. I think they've got a short leg. Of course, that's something you can compensate, but they lose their abduction strength.
Professor Carl.
Yeah, go on, Devendra.
Yeah. At any time, do you do additional plating when you open and do this fixation?
Now, I did previously when I had when I used just two cannulated screws. Sometimes I opened through the anterior approach, and then I used the medial buttress plate. But that was all more or less always in conjunction together with screws. But now, since I've got an angular stable implant, even with Pohl's type 3 fracture, I don't add anything medially to add mechanical support. That's something what you can maybe discuss. But the problem is, as soon as you've got a small plate medially here along the calcar, this little plate will limit any kind of bony collapse. Because you've got screwed proximal fragment, screwed distal fragment, you will not have any bone impaction. I think this fracture healed initially, not here inferiorly, where normally you've got the compression side, because that's where you would expect the bony healing first, because that's a tension site here proximally. I think this guy, he healed first here superiorly posteriorly, then secondarily, he showed bony union on the medial side. And if you have got there a plate, so I think, you see, you don't allow the system to collapse anymore, I think, and that's why you've got the angular stable implant. So you don't need this medial buttress plate for maintaining this reduction in buttress. That's my opinion.
Okay, thank you.
What is the long-term follow-up you have, Carl, now?
So I did the first case worldwide in October 2017. So we've got nearly 3 years now, 18, 19, 20, nearly 3 years now.
So the AVN that you also discussed in one of the paper, like DHS has got higher incidence of AVN.
Yeah.
But we all learned like AVN is majority of the times is at the time of violence, at the time of injury.
Yes.
Suppose if you get good reduction and fixation with any of these implants, AVN is still a possibility, isn't it?
So I think, as you said, I think part of the damage of the vascular supply happens at the time of the injury, but I think also part happens at the time of the surgery. As I've shown you, you've got a huge torque if you use a DHS, and if you twist the DHS, the head only 10 degrees, all the important vascular supply with all the retinical arteries coming from the back into the head, you stretch them, you damage them. So I think part of the AVN is probably also during the surgery, not just at the time of the injury. But I think the AVN risk at this stage is less than 1%, but we've got in our series of 125 patients. We're going to publish it at the end of this year. So we're writing up the paper now, but it's less than 1%. So significantly less. But that's also what you have to say. The average of AVN after neck of femur fracture is 1.4 years.
Yeah.
And the latest patient in this series, they have only 1 year follow-up. But yes, at this stage, we've got a very low risk of AVN.
Yeah, that's good. So that will be a big boon if that works, because if the AVN also can get reduced, because we all feel that though the union can be achieved by many methods, the AVN also is getting reduced, means that will be the big boon. So
that's right. So you can there are a lot of tools that you can improve the fixation, make it stable, make the fracture heal. But to prevent the AVN, I think we're a little bit not useless, but we don't have any tools in order just at the time of the surgery to reduce this risk. Everything else is a little bit out of our hands.
yes. Thank you, Carl. It was superb. So we will also get going with this. So
yeah, I'm looking forward, huh? And maybe because you've got so many cases, you see, I'm really encouraging other sites as well to do a prospective study. Maybe compare a little bit what you're doing so far. Maybe go prospective, randomize your patients, maybe in each group 40 patients, and then compare them. Because I think what we need at this stage, we need really comparison group, prospective, randomized, level 4 studies. So I really encourage you. If you want, you can have our study protocol, what we developed within the AO for those 125 patients. So you could adapt it for your hospital, but I think that would be great if you deliver. I know that you're scientifically very strong, that you can maybe set up maybe research proposal and then come out. And I'm sure J&J, hopefully somebody from J&J is listening as well. They really should support you with any kind of research what you're doing at your site.
What about the learning curve in this technique? So is it too simple, or
it's too simple? It's too simple. Once a K-bar is in,
yeah.
I call it a monkey chop. Everybody can do it. It's really just the positioning of the central K-bar, and then woof, it goes flat. You will see, you will love it, and the nurse will love it because it's so simple, so straight, so easy. And if you just follow those small tips and tricks I just mentioned to you right now, I think you're safe, and the complication rate from the surgical handling and the technique is very low. So you do 1 or 2, and you teach already the third one to a younger registrar.
Oh.
So the learning curve is one case you're at the low level and you stay there.
Oh, thank you, Carl. So
okay.
We will be presenting few of our cases here, and we want to have your interaction also. It's case discussions also will be there. So we'll go on to the next presentation. So thank you. Dendra, yours is the next one. So.
Yes. Before pushing these grafts into the cavity, after cavity, we need to curate the non-union site by using curved curates, and then take out all the fibrous tissue, so that we'll create a cavity, and we can see that we are impacting the bone grafts into the cavity, so that here the particulate material is pushed into the cavity and contained in the cavity, and then we need to ream multiple times by using only the reamer, so that the whole graft gets distributed uniformly without any problem. And then multiple times we need to use this reamer so that it gets uniformly distributed and then gets packed into the whole cavity, and followed by, and while reaming we need to take care that we are not taking the reamer out in the forward motion, forward mode, and then we need to take it out by using reverse mode so that the packed grafts doesn't come out along with the reamer. We need to take care not to bring the grafts out after packing, and followed by we need to tap it and then insert the richet screw, and then we need to do the valgus osteotomy at this stage. We routinely do lateral closing wedge osteotomy below the lesser trochanter. There are osteotomies described above the lesser trochanter as well as below the lesser trochanter. We routinely perform at the inferior border of the lesser trochanter by leaving minimum 1 centimeter of gap from the DHS screw, so that when we valgusize the hip, it doesn't come, it doesn't cut through the lateral cortex. Here, one horizontal cut is made, horizontal cut and angulated cut are made, and then we should not make complete cut towards the medial cortex. We need to stop just short of the medial cortex, so that when we there will be a medial hinge when we do valgusization of the hip. So here the small wedge, 1 centimeter wedge is taken out, and then DHS fixation is completed. So here the important step is we have done a close reduction followed by DHS fixation along with impaction bone grafting, and we are doing a lateral closing wedge osteotomy. Here the important thing is we need to lateralize the shaft of the shaft of the femur, so that the mechanical axis that runs through the knee joint, usually if we don't lateralize the shaft, it goes away from the center point of the knee joint and then cause more valgus. So we need to lateralize the shaft, and so that the mechanical axis is well maintained, and then we can complete the fixation like this. The important principle is that we need to have this instrument. This is a cannulated instrument which is prepared locally, and then this is a trocar which can be used to impact the grafts through the cannulated portion, so that it gets dissipated directly into the cavity. Here we are not opening separate. We are not making any separate opening to pack the graft through the DHS reamer slot. We are pushing this small iliac grafts packed into the small cannulated portion of the instrument. These are the iliac grafts which are completely crushed into small bits. One more important thing is we need to impact the bone graft into the cavity, and it should be uniformly distributed, so that the bone cavity gets filled up, and then it gives immediate support to the both implant as well as the femoral neck as well. This is how we need to pack the grafts, and then important care we need to take care that we are not removing the lateral wedge very close to the richet screw. We need to give at least 1 centimeter of the gap. This is the immediate post-operative X-ray, which shows that the initial X-ray after close reduction, we could see that the tip of the trochanter was well above, and now it is well, it is corrected well, and the line drawn from the tip of the trochanter, it matches to the center of the femoral head. That means that the hip is valgusized well, and also the fracture line appears to be, it has moved from Powell 2 to grade 1 now, and the shaft appears to be well lateralized and fixed with a good lateral closing wedge osteotomy, and both AP and lateral view shows good position of the implant. And immediate post-operative period, we need to check at the knee joint alignment whether there is any valgus alignment, and also the limb length. Many times when we do valgusization, if we take more weight, larger wedge, when we do more valgus correction, there is a possibility of lengthening the limb on the same side. This is 9 months post-operative X-ray, which shows good union both at non-union site as well as osteotomy site, and 3 years later also there are no signs of any arthritis or avian changes. And these are the clinical pictures where patient is able to do all his routine activities, including sitting cross-leg and then squatting, and he is able to walk independently without any pain and limp. So coming to what is late presentation, the definition is if the duration of is more than 3 weeks from the time of injury, it is neglected fracture of the neck of femur. If the duration is more than 6 months, it is called non-union. The incidence of non-union can go up to 34% after surgical intervention. The problems of neglected and non-unions by X-rays, if we see the radiological features of the non-union and neglected neck of femur fractures, there can be sclerosis of the margins, and sometimes we can see resorption of the neck, the increased gap, and avian changes also. The radiological features were classified into 3 stages by Professor H.S. Sandhu, based on the radiological appearance: stage 1, stage 2, and stage 3. Stage 1 is where it is more or less simple fracture pattern with fresh edges, where internal fixation with plus or minus bone grafting, and if needed, if the angle is more, we can do a Powell's osteotomy. Stage 2, where the edges are very sclerosed and non-union is seen. In these situations, to achieve union of this kind of fractures, internal fixation combined with osteotomy and then bone grafting is necessary. Stage 3, where the internal fixation, the chance of internal fixation failures are very high, the hip replacement is suggested. If you look at the availability of bone grafts, the type of methods that have been described to achieve union of these kind of neglected and non-unions, the bone grafts plays a major role to achieve union. And the bone grafts can be either vascularized grafts or non-vascularized grafts. Vascularized grafts, the techniques described are muscle pedicle grafts or vascular pedicle grafts by either fibula or iliac crest. However, vascularized graft techniques require microsurgical skill, and still the possibility of failures are high, and also it is a quite expensive procedures. Non-vascularized grafts like fibula and iliac crest are available. Fibula is a cortical bone which has got more morbidity, and it has delayed incorporation into the host bone. Iliac crest graft is a gold standard technique. It is a cancellous bone which is less morbid, and also it incorporates quite rapidly compared to other grafts. However, the delivering the iliac crest grafts here is very important. Delivery to the non-union site, it makes a lot of difference. And delivering the iliac crest graft by impaction bone grafting is one method we have seen with the good results by using this technique. Impaction bone grafting, the term impaction bone grafting means it is a tight packing of contained cavity defects with compressed particulate bone graft material. The advantage being it gives a good initial support to the implant, it enhances the biology, and it restores the bone stock as well. This is initially used in total hip replacement procedures, and we can use this technique in performing impaction bone grafting for non-union after curettage by packing these bone grafts to the non-union site. And this technique has been reported in Journal of Orthopaedic Trauma recently, and we have seen very good results with this technique. When we compared our technique with the grafting technique available literature, our union time and non-union chances are quite less. Union time is very less. And also when we compared with vascularized grafts, even though the union time and non-union rate are quite less, the avian chances are seen high. But still, when we compared with the existing literature, the available, the non-union rate can go up to 16.4% with all other techniques. But impaction bone grafting, we could see that it is only 11.36%, which is still acceptable. To summarize, whenever we are treating this kind of non-unions with of neck of femur with huge bone defects, we need to address the poor bone stock, and we need to provide the biology. And before that, we need to clear the bridging fibrous tissue, which makes important step to clear the fibrous tissue so that we can pack the iliac crest grafts. And then we need to give a good mechanical stability by using DHS fixation. To conclude, impaction bone grafting with subtrochanteric osteotomy and DHS fixation, it is a novel and relatively simple technique which is cost effective, and it has got a high union rate with less complications and easily reproducible, and it is a easily reproducible technique even with young surgeons also. Thank you.
Thank you, Devendra. Carl, I want your opinion on this. You have to unmute. You have to unmute.
Okay, so yeah, I think it's a great technique. So I think it makes completely sense that you remove the scar tissue and you replace the scar tissue with cancellous bone, and that you transfer a Pulse type 3 fracture, or maybe 2, into Pulse type 1 fracture. So you change the shear force into compression forces. You compensate for a lengthening of the femur by a closing wedge osteotomy on the lateral side. So I think it, as you said, it's a simple, reliable, and good technique. So what I'm questioning, how do you decide beforehand if the head is still vital or not? So do you make it time dependent, or how do you decide if the head is still viable? Do you make a bone scan, or do you make an MRI, or what do you do?
No, radiologically, when there is an evidence of an MRI only, we are going in for investigations to find out. Otherwise, only by X-ray we are trying to, because up to 6 months, all these fractures that we have managed was within 6 months and so. So that is why I'm feeling that in 6 months anyway, still it could be viable. So that is the reason we have not gone in to find out the evidence. So the next idea was, this we have discussed in our team also, like if we know that any of them are avian, then probably if you segregate them separately and do this procedure, maybe our avian rates could be even less.
I think it's a great technique. So you see, that's something I think you have got experience with. We in Europe, we don't see those late presentations of necrophiles. So if you see maybe sometimes a lady, they're from the nursing homes, and they have been lying around for a few weeks, that's for us already a late presentation if it's 2 or 3 weeks down the track. And most often those are elderly patients who are kept in the bed. So in those patients, we go with the hemiarthroplasty as a primary solution. I think your solution is probably more reasonable for a younger population, which we don't have got here in Europe. So we don't have this experience as you've got. That's also shown in the publication. I think you had 44 cases. Nobody else had so many cases before. So I think it's really convincing what you're doing.
So there is a question from the audience. Can we discuss that? So is there any role for biplane double support fixation in delayed presentation? Biplane double support fixation.
I don't know what he means by biplane. Does he mean femoral neck fixation also? I am not sure what he means by that. Carl, do you understand what he means by biplane double support fixation?
Biplane's probably that maybe he wants to add another small plate maybe at the fracture site. So I don't know the same question as you. What does it mean by a biplane? I don't know what. So maybe it's an additional middle plate along the middle hinge. But then you lose all the benefit of doing it just through the lateral approach, which is technically much more demanding.
Yeah.
Of course, if an additional anterior approach, you could see the whole fracture side, you can clean it out, you can impact it from the anterior side, and then bring it from the lateral side. But I don't know what this question is about. Is it for a second plate? I don't know.
What is your approach? Sorry, sir.
No, I think they're putting screws in 2 planes instead of in 1 plane. they go in two planes so that doesn't collapse also will support better. And, probably that's what they mean. Biplane double support.
Professor
Okay.
Carl, what is your approach when the patient comes quite late? Do you straight away go and do total hip replacement, or do you attempt salvaging the hip by any osteotomy? And
They don't get many cases, he said. So that's what he said. So only elderly people they have seen. So.
okay.
Of course, I think if you see a young patient with screws or DHS who come in with a non-new, I think then you probably do the same as you, but we change a little bit. We don't do the bone grafting, we just do the osteotomy. So most often the osteotomy might be sufficient.
Yes, there are large number of presentations where only it has worked only with valgus osteotomy. So it is a new addition. We have added it, and then we found that compared to valgus osteotomy, we are still union rates were slightly better. So that is why we wanted to present it. So
there is one more question regarding Devendra's presentation. So up to how long you can use your technique? What is the cutoff period from delayed presentation? How long you can do it? Is there any cutoff period where you will decide against fixation?
No, the maximum time that we have got non-union here is somewhere around 6 months. Okay. But beyond that, we have not treated anyone. But those who get young patients, you know that in our scenario, there is also like, it is not only like case basis, but sometimes the financial situations, all those things we'll have to take into account. And then a lot of the patients, the first choice is in young individuals, we again think for a salvage. And then suppose if it doesn't work only, then we send them for a replacement surgery. So generally first option is to salvage it.
There's one more question. Can we use double angle DHS? What is your opinion?
Yeah, double angle DHS, some of them have still used it. That is, they just think of valgusizing it. Yes, definitely it can be done. But if somebody is using that, it is better to use blade plate than a double angle DCS. Yeah, blade plate is a good option to do a valgus osteotomy.
In blade plate, is it possible to lateralize the shaft, sir?
Yes, definitely. The entire idea is that. So, Carl, you want to add, because you are an expert in osteotomies.
You see, as you said, I think there are two different types of angular blade plates. The one for the juvenile ones, you have got this double nick in. But I think for corrective osteotomies, you use a straight one, and that's how you can lateralize the shaft nicely. So, and the benefit of using an angular blade plate, you've got also the rotation stability. But with the DHS alone, you may be considered to maybe add on an anti-rotation screw. But I've seen the case where so you don't use anything else to prevent the rotation of the head, obviously not. So you don't need anything special additional to neutralize rotation with the DHS?
No, like what happens is for derotation, we initially start off with having a Steinman pin. So once everything is done, we remove the Steinman pin, only the DHS remains. So, okay. Some of the cases we have added a fibula strut, so that will act as a derotation. So,
okay. So superior to the DHS.
Yes.
Yeah.
Superior to DHS. Yes. Yeah. So we are getting late. We will just move on to the next presentation, and then who is next?
Myself.
Carl, we did a proximal femur last time with Paulo Barbosa. Yes. So that is why all those leftover topics are all now we are discussing here. We wanted FNS from you, and then these late presentations with replacements. So that is why, and then we'll follow with case discussions.
That's perfect. That's great. It's an interesting session, I have to say. I'm learning a lot. It's good.
So good evening, everybody. Thank Dr. Dean Dallin and Dr. Rashikhan for organizing this webinar. I'm going to talk about totally arthroplasty for proximal femur fractures, failed proximal femur fractures. Basically, osteosynthesis is the ideal solution for any proximal femur fracture, especially in young patients. They're able to achieve union, and the results cannot be equal to any prosthetic replacement. So we had enough discussion, but still there are some failures with internal fixation. So sometimes it can go up to 16% following intertrochanteric fracture, especially in elderly patients. So the proximal femur fractures can be either intracapsular or extracapsular. What is the role of primary prosthetic replacement? We use it especially in elderly patient with a fractured neck or femur, or healed young patient with head and neck fracture, major injuries. We do a primary hip replacement. In an extracapsular situation, in an elderly patient with severe combination with osteoporosis with multiple comorbidities, want to avoid the further resurgeries and allow early ambulation, we go for a primary prosthetic replacement. Post failures, we come across non-unions, implant failures, avascular necrosis, and secondary arthritis and infection. These are the causes for late conversion after a failed fixation. For a fractured neck or femur, as we already discussed, young patient we try to salvage. An elderly patient, we can go for a arthroplasty. Reoperation rate in elderly with intracapsular fractured neck or femur is very high, up to 40%. So prosthetic replacement is preferred. Do you do a hemiarthroplasty or a total replacement? There's always a question we discuss. So the latest literature review, meta-analysis from Journal of Orthoplasty, comparing more than 1,800 cases. What they say is, generally hemiarthroplasty is a quicker procedure, especially in an elderly patient with multiple comorbidities, and we are using a large head, so dislocation rates are high. But there is a high incidence of reoperation rate in active individuals. So there can be a secondary arthritis or subsidence with this hemiarthroplasty. A total replacement offers a better function. The high-risk hip score is comparatively better when you compare head-to-head hemiarthroplasty with the THR. And we have a less reoperation rate following subsidence or secondary arthritis in the hip. But the problem is higher dislocation rate. And now we have options to reduce the dislocation rate, which we'll further discuss in the following presentation. What are the problems in treating unstable intertrochanteric fractures in elderly with multiple comorbidities? Your fixation is not going to be very stable, and we need to delay weight bearing and delay mobilization, which leads to prolonged bed rest, and can lead to pulmonary embolism, DVT, and pneumonia. And the hospital mortality rate is very high with delayed mobilization and secondary complication up to 10%, and after 1 year it increases up to 22%. So immediate fixation, early mobilization is the best option for treating elderly patient. If you're not able to do that, then your primary hip replacement is a better option in these patients. So for unstable intertrochanteric fractures, long stem bipolar has been described way back in 1974. At present, we are advising unsymmetric long stem bipolar or a THR. These are papers from Korea and India, which have shown that outcome with a cemented or cementless hip replacement has been good, and especially in elderly patients. And the functional outcome has been good and satisfactory. There is no early mechanical failure. This is an example of a patient with trochanteric fracture with hip arthritis. We did a primary hip arthroplasty, and we are able to mobilize the patient immediately, and the results are good. If coming to failed proximal femur fractures, we can have a trochanteric fracture or a failed head fractures. And we have some unique situation where we have a proximal femur fracture with a distal shaft fracture. These also are causing a unique problem, which we'll discuss further. The failed surgery can be very distressing for the patient due to pain and disability. For the treating surgeon, it can be a challenge to perform salvage operations. It's not like a simple primary hip replacement. So what are the problems with failed fixation? We need to address all those problems because it requires multiple reconstructive modalities. It's not the league of primary hip arthroplasty. It falls in the league of a major revision hip arthroplasty. So we have a previous hardware inside. There is bone loss both on the femoral side and sometimes on the acetabular side. There is osteoporosis, shortening, and loss of abductors. You can see there is a screw causing erosion of the bone in the acetabular side. And you can see the lost osteoporosis and screws backing out immediately after fixation. Can be broken screws, hardware inside. Removing it and getting a fixation is not easy. And the trochanter can be totally, greater trochanter can be separated, lesser trochanter can be separated, and making the hip very unstable. So we need all the armamentarium necessary for removing the broken screws and broken implants, refines and multiple screws, metal cutting burrs. Everything has to be available in the theater before you start this surgery. And coming to the hip reconstruction, we need all the reconstruction options like a modular stem, a long stem, or a stabular reconstruction option with cage and dual mobility. So every time we come across the previous implant, we always should have a high suspicion of infection. We do a ESR CRP and a complete blood count. The ESR CRP is high, we do an implant exit and do a two-stage procedure. We get intraoperative cultures and give appropriate antibiotic and take them up for hip replacement at a later stage. Most of the time, we'll end up using long stem in this situation. Primary stem may not be suitable. So you open up the fracture site, the trochanter is flipped off with the intact abductor attachment. The canal is opened, and we ream the medullary canal with sequential reamers. So this is a Exeter, this is a uncemented long stem option from Wagner. We use hand reamers, we use the trial. And, getting a distal fixation is very important. Proximally, there is bone loss, and we need to reattach the soft tissues. At the stage of trial reduction, the soft tissues are not reattached, and we use the opposite limb for comparing the limb length. That's how you restore the limb length. So always you should know where is the position of the opposite limb. The opposite limb should be available to check your limb length. So we'll deal with the individual fracture. This is an example of a femoral head fracture. We can see femoral head has been fixed with Herbert screws, and it went into avian. And this is a simple, straightforward total hip replacement. We go through the previous approach and restore the limb length, offset, and stability. Coming to intracapsular fracture, this is a patient with a fracture neck of femur with avascular necrosis, and patient has been walking on this. We can see the shortening and pelvic tilt. In this patient, we did an uncemented hip replacement, and we used a metaphyseal fixing. Proximal cannot afford uncemented process. We used a cemented system. Only thing, when you're pressurizing the cement, the proximal holes has to be blocked so that we get enough pressurization distally. But you have a long DHS plate or a long nail like this, cement pressurization may not be easy. Here we can see the lesser trochanter is intact, so we could use a cemented system. Again, the cementation is on the femoral side has been achieved, and the trochanter has been refixed. But when you have multiple screws, broken screws like this, and we remove it with the trepine, there is a lot of bone loss. Here is very important. When you're using a distal loading stem, you always should bypass the stress rises. Another example where there is a failed proximal femur fracture, the failed PFN in doctor, physician, and you can see there is a lot of proximal femoral bone loss on the lateral side, especially because of the proximal femur combination. It's a biological failure because patient had rheumatoid arthritis, uncontrolled diabetes. So it's a biological failure. Fixation has been adequately done. So in this, we reconstructed the long stem, and you can see there is a small void here. We used the femoral head to reconstruct the proximal femur. The entire femoral head was intact. So in the proximal lateral part of the femur, where there is a void, we have put a small femoral head allograft. We have reattached the greater trochanter. The end of 2 years follow-up, we can see the proximal femur. We can see the abductor mechanism continuity is restored. The whole proximal femur is healed. So reconstruction of the abductor mechanism is very important to prevent further redislocation. It's a very important part of proximal femoral reconstruction. You can see this patient, trochanteric fracture, comminuted fracture, screws backing out because of osteoporosis, and the great trochanter is separated. So when we are doing that long stem THR, we are reattached the trochanter with multiple wires, and the abductor mechanism continuity has been restored. It's very important. So, but we did it very prosthetic fracture. Both intra-op and post-op fractures are very high, up to 6%. Infection rate also high, 3.8%. And dislocation rate 11%, and reoperation rate 10.9%. This is the literature we see the recent literature also has not changed much. The complication rate is, you can see 7.5 versus 4.5, comparing primary THR with failed fixation. Again, the DHS, the chance of intra-fractures are very high, and the infection rate also are high. These are the recent literature. So this is an example where I had a multiple complication with this patient. 65-year-old lady, obese, IHT, diabetic, had a failed proximal femur fixation. CRP was equivocal. We did the primary THR, but immediate post-op patient developed acute infection with Klebsiella. So I had to go back and remove the prosthesis and put a temporary spacer. And the entire proximal femur, we need to debride to remove all the infection. There is extensive bone loss on the proximal femur, and it was very unstable. And after the infection settled, we went in and realized with a long stem. Patient did well for almost like 4 years, but again she developed recurrent dislocation. So finally the cup was loose and had to go for a dual mobility. So nowadays we are using more of this dual mobility cup, which will prevent further dislocation, especially in patients with proximal femur bone loss. This is one patient where this is a basic trochanteric fracture with intact calcar. I used a primary proximal loading stem. Post-op patient developed a fracture. We have to revise with a long stem. So always we keep a long stem during surgery, and if we feel the primary fixation may not be very good, there is a chance of developing intra-fracture, we change over to a long stem. Identifying intra-fracture is very important. We always use the C-arm to check the stem fixation after doing the trial reduction. If you have any suspicion, better to change to long stem intra itself. This is an example with severe osteoporosis, neglected fracture neck of femur. While doing the trial reduction itself, the calcar broke. And when we did the wiring and cemented the cup and stem, we tried to reduce the patient developed a fracture distally. So because the high rating hip and very tight reduction, while trying to reduce, patient developed distal femur fracture, which has to be fixed intra itself. So identifying any intra problems and addressing it is very important. The patient went on to heal and walk normally. So when you see patients with failed proximal femur fracture fixation, so you look at the previous hardware, you have to rule out infection, address the bone loss, and also address the shortening intra, and have to reconstruct the abductors and also treat the osteoporosis. So we use pre-op hip aspiration or staging as a method to address infection. We have been using long stem processes with the dual mobility. We always reattach the trochanter to the proximal femur, and we treat the osteoporosis post-op. So to conclude, hip arthroplasty is an effective salvage procedure for failed femoral fixation, poses technical challenges and has higher complication rate. Most patients have good pain relief and functional rehabilitation. Thank you very much.
Thank you, Dhanashekhar. Extensive and many interesting issues you presented. Carl, anything that you want to suggest in those?
I think the summary was good. I think you mentioned it, the complication rate regarding the dislocation number one, number two is the infection, and three to osteoporosis. I'm a little bit surprised that you use so often long, fully porous coated cylindrical stems as your implant, because we know that the incidence of intraoperative periprosthetic fracture is probably 4 times higher than you use a cemented stem. So we've got a little bit of different philosophies. What we do is patients above 70, they get more or less cemented stems, even short stems or long cemented stems, doesn't matter. I haven't seen one single long cemented stem in your case series. They were all fully coated long cylindrical stems. This stem is very uncommon in Australia and in Europe. It's mainly the US, England are using this a little bit, and obviously in India. So I think you don't want to make the complication list longer by adding an intraoperative periprosthetic fracture. So I think that's the only point I was a little bit surprised that you so often those kind of stems. But otherwise, perfect call. Yeah.
So I did show one long cemented stem with a dual mobility in a patient with failed proximal femur fracture with removed implant. And we did a spacer, and second stage I used a long cemented stem. So if the patient does not have a previous DHS, then it's possible to use a long cemented stem. If the patient has a previous DHS, When we remove the screws, there are multiple screw holes through which we cannot put the cement and pressurize the distally. So in those scenarios, we use a long stem distal loading stem. This particular stem has a smaller offset, and I agree this increases the chance of reprocessary fracture, but this offset of this stem is smaller. The other video I showed, I used using a long stem Wagner. Wagner has a very long offset, more suitable for European and American type patients. For Indian Asians, we cannot use a long patient with a long offset, stem with a long offset. So I use this type of stem. Now with the use of modular stems, I stopped using this full sporo-coated stems. So we have stopped using these sporo-coated stems. We are using a modular stem if you need a shorter offset, or a Wagner type of stem, which is a titanium stem and conical stem. The chance of intra fracture is relatively low. So we also use long cemented stems, but I had a major catastrophe with long cemented stem. One of my patients developed intra cement embolism and collapsed and had a cardiac arrest. And now I moved on to fully uncemented stems. So the chance of having a fat embolism, cement embolism with the long stem is very high. So anytime I use a long stem, I use an uncemented stem. I have 3 options: fully poro-coated, or a Wagner type of conical stem, or a modular stem. When you have the for a basic trochanteric fracture where the calcar is intact, I have both options, both cemented and uncemented. Both options I showed in my presentation. So you're on mute, sir. Please, sir.
Dhanshekar, in these revision surgeries,
Yes.
sometimes this trochanter tip or trochanter portion
Yes.
can dissolve into some type of avascularity may set in, and then they get resorbed.
Yes.
How is the function in those patients? Because in one of the X-ray, one of the patient, we saw that the entire trochanteric tip as well as the lateral wall was resorbed.
Yes.
What is the function in those?
So one thing in this patient's exposure, we need to protect whatever leftover abductors are there. Try not to dissect too much and preserve the abductor mechanism. So if we can resuture the vastus and conjoint tendon together, the tendon heals and there is a reasonable abductor function. Sometimes we do come across patients with no proximal femur, and they are all relatively doing well once the abductor heals. We put them on a brace for some time so they don't dislocate. It's similar to doing a proximal femur replacement for tumor. Sometimes we do this massive tumor resection and we do a tumor prosthesis, and just we reattach the muscle with the ethibond to the proximal femur implant. They all heal well and they develop subsequent muscle attachment, and they are all doing reasonably well. With the use of large head, the dislocation rates are reduced. So, but we need to tell the patient we need to go slow on rehabilitation. It might take up to 1 year for the abductor mechanism to heal, and they are doing reasonably well.
Thank you, Dhanshekar. We'll move on to the next presentation. So,
Thank you.
Well, Murugan.
Yes, sir.
Yeah. Any questions are coming in between? Dhanshekar, let us know. Well, Murugesan can start.
Yes, sir. We are able to. Is my screen shared, sir?
No.
Now it's starting. It's visible.
Yeah, thank you. Yeah. I'm Dr. Vel Murugesan. Good afternoon to all, and let us go to the case discussion. First is trochanteric fracture, tip comminution, and avulsion fractures. These avulsion fractures are a result of a combination of direct injury to the trochanter and sudden contraction of the muscle forces. When there is a sudden contraction of gluteus muscle, it results in a large trochanteric avulsion. And then when there is a sudden contraction of a short external rotators, it results in a short trochanteric avulsion fragment. And to understand this, let us look at the anatomy. Gluteus medius has a wide attachment and it is continuous with the vastus lateralis with the thick periosteal sleeve. Even the wide attachment, the anterior part is muscular and the posterior tendinous part is attached to the posto-superior prominence of the trochanteric eminence. And when this broad attachment is intact, it is perpendicular to the avulsed trochanteric fragment. So it prevents the displacement of the avulsed trochanter. But when it is torn, it results in the short external rotators pull it backwards, upwards, and inwards. This is because the short external rotators are attached to the medial side of the trochanteric eminence. And this is this 65-year-old gentleman. He presented with left hip pain following a fall from stairs. He had a large trochanteric avulsion fragment, and on the AP view, which is fairly not displaced. This is not displaced because the gluteus medius and vastus lateralis with the thick periosteal sleeve is still intact, and this prevents it from displacing. But when we look at the CT scan, here also we find that the fractured fragment remains in the same position, but the proximal neck and the head fragment gets displaced posteriorly due to the pull of short external rotators. This results in disruption of the abductor mechanism, and this must be reduced to restore the abductor mechanism back. So we have done an open reduction and cancellous screw fixation, and with this patient underwent the cancellous screw fixation, and the minimum, and he had a follow-up of 2 years with no abductor lurch. This patient here, he presented with the small trochanteric avulsion fragment, and in the AP view we find that the trochanteric avulsion fragment is displaced, and in the lateral view this is the fragment. Though this is displaced and the posterior tendinous part of the tendon is attached to this fragment, the remaining anterior muscular part of the gluteus medius is still attached to the main greater trochanter with the thick periosteal sleeve continues with the vastus lateralis. So these patients can be treated conservatively if the MRI shows there is no signal intensity crossing the midline in the coronal section. If there is a signal intensity which crosses the midline and extends to the lesser trochanter, we must consider a fracture line extending to the lesser trochanter. And this patient was treated non-operatively. He was given bed rest till pain subsided and started on session with the support for 4 weeks, following which he was allowed to weight back as pain permitted and started on active exercise. At 6 months, he was able to walk without abductor lurch. So here we have a A2.2 trochanteric fracture in a 74-year-old lady with avulsed trochanteric fragments, avulsed greater trochanter fragments, and these avulsion and appear as a double shadow in the traction view. We see a twin peak sign in the trochanteric tip. If this is because when it extends beyond the vastus lateralis ridge, we have to reconstruct the lateral wall during the fixation. But in this case, the fracture has extended above the vastus lateralis ridge. But the problem we face with this kind of fracture is we will have difficulty to determine our entry point. So most of the time, our guide wire passes between these two fragments, and if we continue to ream and pass the nail, our nail enters between the avulsed trochanteric fragment and the main trochanter. So this becomes a problem, especially when there is a large posteromedial fragment and a thin lateral wall. This will result in an unstable fixation. And this avulsed fragment can be reduced by using a simple technique. We use a bone hook. We pass it posterior to the trochanter and hook it around the intertrochanteric crest and pull it laterally and outward. And once this is done, we will be able to see the trochanteric profile as a whole instead of a double peak sign or a double shadow. So once this is achieved, we secure the trochanter with an anteroposterior wire and hold it in traction so that we can take an entry just medial to it. And we can do a regular proximal femur nailing. This is a 1-year follow-up. Patient was fracture is united well, and the trochanteric fragments are well reduced. And she was able to walk without any abductor lurch. This is a surgical video of the above mentioned technique. Here in the traction, we see that fragment is comminuted and it is displaced in the lateral view also. We make a 10 centimeter incision starting just below the trochanteric flap and extending it 2 centimeter above the trochanteric tip. We use the bone hook. We pass it just posterior to the trochanter and hook it around the on the posterior side, the intertrochanteric crest on the displaced fragment, and pull it laterally, so that we are able to see the entire trochanter as a whole, and we make an anteroposterior drill hole with the 3.2 mm drill bit. Once this is done, and at 1.25 mm stainless steel wire is passed anteroposteriorly into the coronally split fragment, and it is held in traction so that the fragment is pulled laterally. And a similar anteroposterior hole is made into the shaft, and stainless steel wire is passed anteroposteriorly into the shaft. And this is also once it is done and it is left in position, and we make a we hold it with the cocker and pull it back. And once this is done, and we see that both the fragments are well reduced. Now we make a supratrochanteric entry, a supratrochanteric incision to make the entry point for the nailing. In here we take the entry just medial to the avulse fragment and in the AP view, and center in the axial view. Following this, the guide wire is passed and serial reaming is done. And once reaming is finished, we pass the nail and of adequate length, and then proximal and distal locking are done and into the trochanter and shaft. So now we pass the nail gently, followed by proximal locking. So here we find that both the trochanter and the trochanteric fracture and the comminuted trochanteric avulsion are reduced well. So in conclusion, in isolated greater trochanter fracture needs fixation only when the gluteus medius vastus lateralis attachment is disrupted. And in case of small avulsed fragments of the greater trochanter, we need to do an MRI to rule out intertrochanteric fracture extension. If the signal intensities does not cross the midline in the coronal plane, they can be treated as an isolated greater trochanter fracture and treated conservatively. In intertrochanteric fracture with displaced GT fragments, the reconstruction of GT fragments helps in getting us a correct entry point, and also when there is a large posteromedial fragment, and it will provide containment of the proximal part of nail within the proximal femur. And this will also help in restoration of abductor mechanism. Thank you.
Carl, this is one area where a lot of discussion is going on, like trochanteric tip fractures or a trochanteric tip associated with lateral wall. This is a hotly discussed topic nowadays. So what is your take on this? Unmute yourself. Unmute.
I think, as you said, it's one of the hottest topic at this stage also in all the periprosthetic fractures as well. So you see, very seldom you've got the one single large piece where you can deal with. Most often it's comminuted situation. We don't know yet if it's better to include it into the fixation. Let's say if you've got V1 fracture, you played it laterally with the plate. So the question is, should you include also the GT for the whole construct, or don't you do it? And then the second thing is the kind of fixation. So you see, you have got a technique where you pull through the proximal fragment and then distally, and you connect them. A lot of surgeons, they use K-wise, and then they tension it over K-wise. Some surgeons, they use small hook plates and then go with two cables around the needle calcar. Some surgeons, they combine proximal a ring plate with some locking screws, distally with an extension of the plate. So I think at this stage, it's a little bit like neck of femur fracture. I think it's an unsolved problem. First of all, the indications are not absolutely clear, and also the rehabilitation sometimes postoperatively, because we know that in deep flexion, you've got higher force on the GT fragment for anterior superior displacement, and also the implant itself. So yes, it's an ongoing issue, and I think nobody has got at this stage really the solution for this problem. We're all trying to do our best. So should we do a single figure of 8, a double figure of 8? Should we do the Charnley type of contract, bucket with two stripes distally? It's hard to say. I think at the end of the day, probably the most important is that the sling remains intact. So I think at this stage, what we're trying to do in the cadaver lab in Davos, we don't really focus in trying to fix the fracture back, but that we restore the sling from the gluteus medius to the vastus lateralis. So maybe that's another idea, that you maybe can neglect the bone, but maybe just look at the tension band of the lateral soft tissue, which at this stage nobody has ever looked at. How important is it maybe just to fix the two hands back and lift the bony fragments alone?
That is the reason I asked Vel Murugesan to prepare this topic, because we know that we are doing this Hardinge approach, we are doing this Watson-Jones approach. We are keeping it as a full sleeve, the vastus lateralis and gluteus medius as a full sleeve. So that definitely functions. That is why I also asked Dhanashekhar about that. Whenever there is a resorption of the gluteus, that is a trochanteric tip, or a lateral wall function that is there by the soft tissues. So that is why I was asking him. So that is why this pictorial representation, we wanted to make it so that the understanding is better about this sleeve. So I also, the concept is like a patella fracture. When there is a patella fracture is there, unless there is a retinaculum that is ruptured, patient still can do a straight leg rising. So that's why maybe we may not treat it. So when you are exposing, when you are seeing that the sleeve is intact, maybe there is no need for fixation.
Absolutely. I think at this stage in the research also a little bit more important than the bony fragments per definition. Absolutely right. Yeah.
Any question, Devendra? Anything from you? Okay, then we will move on to the next one. So it is in continuation with. So before Zakaria talks, Ramesh is finishing, no? Ramesh?
Yes, sir. Am I audible, sir?
Yes,
Is my
yes.
slides are getting shared?
Yes, yes.
I'm here with presenting the trochanteric fractures and osteoporosis. This 74-year-old female who had a domestic fall and sustained an injury in the right hip, and she's unable to walk. And I hope the X-ray showing the unstable trochanteric fracture. I'm certain that in this type of fracture, as per the Yoga classification, it comes to 322, and patient doesn't have a medical illness. So in this era, everyone will accept PFN is the treatment of choice, where it gives a good and early mobilizations can be achieved with a good uneventful outcome. So the post-operative care following these injuries are, we encourage all the patients to walk early weight bearing, and static physical exercises are given. And as a part of nutrition, we give vitamin D supplementation 60,000 units weekly for 8 weeks, and give calcium supplement is being given, and patient was discharged on 4th days. This is the patient 6 weeks follow. X-ray satisfaction, and we tell them to continue the medications and also physical exercise, and we ask them to review for another 6 to 8 weeks time, so that by 3 months time the fracture would heal in a better way. Unfortunately, this patient was lost to follow. This patient didn't come for the other follow, but at 1 year she again had a repeat fall and had a pain in the left hip, and she was unable to walk. So in this, see, you can see there is an intertrochanteric fracture on the left side. Of course, all of you will accept the management would be doing a similar kind of procedure or a DHS fixation. So in our experience in the last year of 253, particularly the trochanteric fractures, when we analyzed our series, we had 16 patients who had a refracture, who had a trochanteric fracture fixation done on the other side in the form of a DHS or a PFN, and sustained an injury on the other side. It was 6.3%. But when we analyze the literature, the refracture incidence in osteoporotic individuals is up to 15 to 20% for the hip, maybe up to 40% in the spine. So this patient underwent a similar kind of PFN nailing for the left side also. The postoperative care, along with the regular physiotherapy vitamin D and calcium supplementation, we did an osteoporosis workup. So we have an endocrinologist full-time in our hospital, and we have got an osteoporosis clinic with a proforma, which includes the history details of the patient, particularly about the status of steroid intake, rheumatoid, the presence of thyroid problems, and also we do a DEXA scan for all of our patients who sustain a hip fracture after the age of 50 years, and we look for the baseline markers like serum calcium, phosphorus, and alkaline phosphatase. And also we look for the albumin level, because hypoalbuminemia can cause a reduced calcium binding. Patient can have an osteoporosis. And also the serum PTH level, which gives an indication for a primary or a secondary hyperparathyroidism in all these patients. And also baseline renal function to restart or initiate the amount of biphosphonates or the terifluc injections. So this patient we gave, since the T-score was -4, we gave an anti-resorptive like zeranonic acid infusion was given at 6-week follow-up. This is a 3 months follow-up. We can see fractures quite healed well on both the sides. This is a 3 years follow-up. And at the initial point of time, we did a DEXA scan, which showed an T-score was -2.5 increased, but in the initial time it was up to 4.5. So the T-score is reasonably improved with the zeranonic acid for 2 years time, and also in the hip part it has been improved from -3.5 to -2.5. So the consensus of biphosphonates in fracture healing is a few studies came indications of biphosphonates in fracture healing, particularly there is a fracture healing. We have done our own experience in the last 2 years. We had 123 trochanteric fractures. In group 1, zeranonic acid was given at the time of admission. 6-week follow-up, a timing of zeranonic acid was given, and group 3 only a vitamin D and calcium supplementation was given. We analyzed the relationship of fracture healing along with the zeranonic acid infusion in different timings. The union rate was reasonably similar, and there was no statistical significance in the healing time when the zeranonic acid was administered at different period of time with evidence of control group. So, and also we concluded that biphosphonates can be administered safely during the fracture treatment. As in these individuals, it is important to treat the patient with surgical implants, and also correcting the osteoporosis of paramount importance in identifying these patients to prevent secondary fractures. Hence, to conclude, the surgical management is an important option for early ambulation in these injuries. And of course, the vitamin D and calcium are essential for coping with osteoporosis, but workup for osteoporosis is very essential, as the treatment of osteoporosis is equally important to prevent fall and refracture in the future. Thank you very much.
Thank you, Ramesh, for making the point very clear, because a lot of people would like to know. There was some vague idea that bisphosphonates can inhibit fracture healing. So that is why we also did that study, and it's good that we are speaking. We want to take Carl's opinion also on this.
So I think you probably confirm what I think I've read before, that you can start with biphosphonate at the time of the surgery, so you don't need to write. I think there are a lot of what we do sometimes a similar approach. So we give every patient, they get vitamin D and calcium 4 weeks. So it's a very high amount of vitamin D dose in the first 3 weeks. But you've got maybe the reason why. So what we do normally, we give 5,000 per day. That's 5 by the amount what we are giving. I think that we do that the same. But what we do is we don't measure it with each patient the BMD. So what we do is we calculate the FRAX score. You probably know the FRAX score, what you can do online. So what we do is in the ED, we do the calculation. If the risk, depending on the age of the patient, is above 20%, yes, then we start with a medication. Normally what we give to the patient, we give them alendronate, Fosamax, 70 milligrams once per day. So we don't do any kind of infusion. And I think you're absolutely on the right spot. I think if you look at the literature at this stage, only 20% of all the ED departments, they really fractures. I think if you do it routinely, of course, it may be reduce the number of the cases for the future. Maybe that's bad for your business.
No,
Definitely, but maybe definitely you're doing something good for your
we
patient.
want to reduce it.
You've got too many cases. Okay. I think there's an interesting study. I think it just came from Japan, where they started with Fosteo. So Fosteo is synthetic parathyroid hormone, which is from we can't give it unless we pay. But in China, what they found is giving this synthetic parathyroid hormone that the numbers of non-unions has significantly decreased. But you shouldn't give this medication for a prolonged period of time or some cancer. That's something I'm taking with me. Maybe we have to increase it. And yes, I support your approach to the biphosphonate. You can start immediately at the time of the surgery.
Ramesh, what happened?
Question. Do you send the patch? Because that's what we do routinely. Before you also check it. Okay.
Yeah, it's an excellent point. The allodonates, the osteonecrosis jaw has been reported. It does not correlate with the duration of the treatment, but usually it is seen in patients who have got a lot of dental caries and patients who undergo dental extraction. They are more prone to develop osteonecrosis of jaw. That's a very valid point.
Ramesh, we also did a study on zoledronic acid and also denosumab, no?
So that one, the denosumab, the current consensus are treating an osteoporosis. The combinations are coming up in the form of denosumab and parathormone. So the denosumab as the combination has been accepted for osteoporosis treatment in extreme cases like when the T-score is -4 or 4.5, where you want the BMDs to come up quickly so that we can combine both these treatments.
Ramesh, thank you. So we'll move on to the next one. So
thank you, sir.
Then Shekhar, any questions are there? You can let us know. Or
we'll after the next discussion,
we'll take it at the end. Yes. That area can go.
Yes, sir.
Let it be short so that we'll finish it at the right time.
Is my screen visible, sir?
No. Yes.
Is my screen visible, sir?
Yes, yes. Go ahead.
Yes, sir. Is my screen visible, sir?
Go on. It's visible. Go on.
Yes, sir. So I thank Professor Rajshekharan and Dr. Deenadayalan for giving me this opportunity to speak on this podium. So I would like to speak about the lateral wall reconstruction. So trochanteric fracture is still a major orthopedic challenge worldwide. Trochanteric fracture with posteromedial comminution, reverse oblique pattern, and the subtrochanteric extension are generally considered seems to be a determining factor in the stability, and hence the trochanteric fracture within lateral wall involvement is considered to be an unstable fracture pattern. So lateral wall is defined as the proximal extension of the shaft. In other words, it is also described as when two lines drawn in the superior and inferior aspect of the neck, and when extended laterally, the part of the trochanter which is between the two lines is called as a lateral wall. And any fracture in this area is called as so usually a trochanteric fracture is usually stabilized with a DHS plate, but there are incidences where there's an intraoperative and postoperative lateral wall fracture also. So we have done a study wall fracture after DHS session. So in this study, we have concluded that lateral wall fracture during DHS fixation is common, and there is 19.4% incidences, and all these fractures had a poor outcome. It is also concluded that the lateral wall thickness is a good predictor of an intraoperative lateral wall fracture, Whenever the lateral wall thickness is less than 21 mm, other mode of fixation should be done apart from DHS fixation. So this is an example of a trochanteric fracture. DHS fixation was done. Intraoperatively, lateral wall fracture was not addressed. In the subsequent follow-up, if there is we can see that there is a varus collapse, medialization of the shaft, and finally, it has failed. So overall fracture during DHS fixation, it is always advisable to study with an stabilize with an trochanteric stabilization plate. DHS fixation, the fracture was reduced, guide wire was inserted, triple rimming was done, and the DHS fixation was done. During intraop, we noticed that there is a lateral wall fracture, and stabilized with an trochanteric. See that the lateral wall fragment. If there is in preoperatively, it is found necessary. Whenever there is valgus reduction, medial positive variance, an anterior cortex community, and where there is an intramedullary implant, you don't need to fix all the lateral walls. So this is an example of an trochanteric fracture with a lateral wall fracture. So we did a closed PFN nailing. So you can see there is a valgus reduction, medial cortex continuity, and an anterior cortex continuity is there. At the end of 9 months, the fracture united unevenly in spite of the lateral wall fractures. This is another example of a trochanteric fracture with a lateral wall fracture. You can see the lateral wall fracture was there. We did a close reduction and a nailing, a PFN nailing was done. In the post-operative X-ray, you can see that there is a valgus reduction, medial cortex continuity, and an anterior cortex. So you can see in this X-ray that after 9 months, this fracture also united unevenly. So this is another example of we have planted that is a negative variance and that is a straight varus. So the first month post-op X-ray, nothing was seen, but in the third month post-op X-ray, we can see there is a varus, there is the negative variance is increased. In the subsequent and 5th and 7th month. So since this patient is a 65-year-old female, we end up doing a total hip replacement. So when you retrospectively analyze that, why this fracture has failed, in this fracture there was an anterior cortical continuity was there, but valgus and positive variance was not there. And when these three, this one is absent and the lateral Webster also is absent, it is there is varus collapse and failure. In our institution, we studied the lateral wall fractures, and we have come. We were very surprised to see that there were a lot of money. To simplify this, all lateral wall fractures we have classified into 3 groups. The first is a single large lateral wall fragment. The next is a coronal split of the lateral wall fragment. The next is the bust fracture of the lateral wall fragment. When there exist so many different lateral wall fractures, there can't be a unified technique for reconstruction. Hence, this lateral wall reconstruction has to be a morphologically specific lateral wall reconstruction. But anyway, these morphology specific, and this technique and the classification of the lateral wall were recently published in the paper and has been accepted. So this single large fragment of the lateral wall. In the first two CM pictures, you can see that it is a 3-part proximal humerus fracture with a large lateral wall fragment. In the next picture, you can see that all these reconstruction technique are done in open reduction with a 6 centimeters incision centering over the trochanter. In the next 2 CM pictures, you can see that the fracture is reduced with an Homan retractus, which is temporarily held with 2 K wires. So once the fracture is reduced and circulage wire is passed around the abductus and distally looped in the shaft with a drill hole in the figure of 8 fashion. So once you tighten this lateral wall gets buttressed. Once the lateral wall fractures is reduced, it is easy for us to get the entry, which is always slightly medial to the tip of the trochanter. Right, regular nailing is done. We did a PFN nailing. In the final post-op X-ray, you can see that the lateral wall is well buttressed. Medial cortex continuity is there, and in the lateral view, you can see the anterior cortex well reduced. So this is how we do a lateral wall reconstruction when there is a large lateral wall fragment. The second technique is that whenever we have a coronal fracture of the lateral wall. In this technique, first the shaft is reduced with the proximal fragment. It is temporarily held with a K-wire. So once this is done, then we can address the coronal split of the lateral wall fragments. The coronal split of the lateral fragment is reduced held with a K-wire or Hohmann's clamp, and through drill is made in the coronal wall with the help of a drill bit or a Steinman pin. A loop is passed. The loop is distally anchored in the shaft in a figure-of-8 fashion, and it is fastened. So once the lateral wall sleeve is being maintained, you can do a nailing. You can take an entry medial to the tip of the GT. Regular nailing procedure is the cephalic screw is fixed. In the post-operative picture, as you can see, the fracture is well reduced. In an AP view, medial cortex continuity is there. The fracture is in valgus. In lateral view, you can see that anterior cortex continuity is there, though those shows a slight comminution. And these pictures are depleting there. The third one is the lateral wall reconstruction, the bust fractures. In these fractures, anatomically, it is very difficult to reduce these fractures. The aim of circulage wiring in these fractures is to maintain the abductor mechanism and to prevent the medialization of the shaft. For this, the loop is first around looped around the abductors, distally in the shaft. Without fastening, we have to hold the loop. You can reduce with the help of an Hohmann retractor, temporarily held with K-wires, and nailing is done. And finally, the loops are fastened. Now you can see in the final X-ray that the lateral wall is buttressed. Though anteriorly there seems to be a little bit of overlap is there. In these kind of difficult fractures, whenever the valgus is there and the middle cortex continuity is there, these fractures go on to heal. So take-home message is that IT fractures with lateral wall disruption are highly unstable. Valgus reduction, positive variance, and anterior cortical continuity and use of an intramedullary implant, there is no need for lateral wall reconstruction. When any of these three variants are not achievable intraoperatively, then lateral wall has to be augmented. And lateral augmentation always should be with a morphology-specific lateral wall reconstruction. Thank you.
Thank you, Zakaria. So, Carl, what do you think of this? Because lateral wall reconstruction, see, like now, as you rightly said, there are so many wires, loops, plates, multiple varieties of plates, screws. So,
I have to say, I've never looked at the problem so much in detail as you did. I think that you came up with this classification, what kind of lateral wall fracture. I haven't read those publications, to be honest. I think it has been published in, I think, the Indian Journal of Orthopaedics. And yes, I think it is a problem, but most likely we don't take it too seriously. And I have to say, I probably have to go back myself, because most of the time we use the nail. And with the nail, even if there is a lateral wall fragment there, we just don't bother. So we don't really reattach. We probably reattach it if the GT is displaced, but we don't really look at this lateral wall fragment enough, even if we use nails. So I think a point that I can take with me today is probably that we go back and we probably analyze our implant failures using the nail. how often did we have, and what kind of lateral wall type fracture, and does it correlate also with the failures? Obviously, you found the correlation. You said as soon as one of those four elements are missing, that you maybe have to consider to do this lateral wall reconstruction. If it's sufficient, but obviously you have got more experience than I do, just to use those tension band technique before you insert the nail. Obviously, that's a technique, but I have to say, I wasn't really aware that that might be the problem, even with intramedullary nailing.
No, we grew without fixing the lateral wall for many decades actually. Like so now only in the last probably 2 to 3 years, this has become like a big catching point for all these nailers and platers to discuss about the lateral wall. So what we have found is that if all the three elements are good, so there is no need for fixation of the lateral wall at all. So that's why I wanted to ask your opinion also.
Yeah, but obviously there's a need to fix those under certain circumstances. So if you've got a varus situation, if you have got the anterior index is not correct, can maybe the presenter just before leave his presentation? Would that be so I can see you? Would that be possible?
Zakaria, stop sharing. Stop sharing.
We'll stop sharing, sir. Yes, sir.
Okay, thank you. Yes, so as I said, so you're probably not aware enough. So at least me, of course, with the plates, we know exactly with the plates we've got this issue. But if you see a lateral wall fracture, very often we go straight away to use a nail. So we don't use the TPS, a trochanteric buttress plate. We don't use it. I've seen a few cases where you use this plate. So obviously, it's still quite common in India that you use a trochanteric plate in conjunction with the THS. It's hardly ever used in Europe because
here also we don't use this. That X-ray was from many years ago. So, but our study was to say that from the evolution to the now, we found that these.
Number one is a 30 years old male who presented following a road traffic accident and presented 12 hours after the injury. There is a basic cervical neck with a comminuted shaft fracture. So whenever we see this X-ray, the following things we run through our mind: whether should I use a single implant or should I use 2 implants, and whether the fracture is stable, which fracture to stabilize first, and what should be the patient positioning. So if you see the algorithm, how to proceed. So basically what we can do is we can look at the position on the fracture table. You may put the patient on the fracture table and look at the fracture alignment. If you're able to get a reasonably good alignment of the neck, you can try with a closed reduction technique. Here sometimes you may have to use the derotation pin in the shaft as shown in this diagram, that arrow mark, red arrow mark, which shows a derotation pin. So you have to derotate the shaft, and then once you get an anatomical reduction of the neck fracture, you can secure it with a Steinman pin, and then you can finish off your nailing as a conventional method, recon nailing, and then you will get a reasonably good alignment. When it comes to the shaft fracture, you can use this external fixator as the shank pin as a joystick technique. So here we can adjust the position of the shaft, and then we can pass in the guide wire, and you will get a reasonably good alignment with a single implant. So as long as the neck fracture is minimally displaced and you get a reasonable alignment on the fracture table, single implant can be safely used and will give a very good result. And this is the final follow-up of the same patient. He had a fracture has healed well, and he got an excellent range of hip movements. This is a similar case scenario, and a 57-year-old male who presented following a road traffic accident with a basic cervical neck and a comminuted shaft fracture. Again, reasonably able to get a good reduction with a single implant. And this is the final follow-up. So this is another case scenario. It's a second case scenario where there is a 19-year-old female. She also met with a road traffic accident, but this is a slightly higher violence injury, because you can see that there is also ipsilateral tibia fracture as well. as well as the femur shaft. So if you calculate the Powell's angle here, it is almost comes up to 80 degrees. So it is like a shearing, much of a shearing force is there. So these kind of fractures, generally you have to think in terms of stabilizing the neck fracture. Maybe you have to think of a primary osteotomy as well, because you need to convert the Powell's type 3 into at least Powell's type 2 to reduce the shearing force. And then, so this patient, we decided to do take an wedge osteotomy, lateral wedge osteotomy, and then we corrected the neck shaft angle and brought it into Powell's type 2. And then we were able to get a reasonably good alignment, and then we fixed with a DHS, two-hole DHS fixation. And then once the DHS fixation is done, then we repositioned the patient and did a retrograde femur nailing. So this was a 2-implant scenario where we used 2 implants, and the TBI also nailed separately with a intramedullary nail. And this is at a 6 months follow-up. This fracture is healed well, and this is at the end of 3 years. Maybe there is a slight head showing some avian changes, but patient is doing very well. She's able to do all her routine activities. This is the patient walking, and you can see there is no any limp, and reasonable good range hip movements. So when the severity of the neck fracture is more, you may have to think of a primary valgus osteotomy when the neck fracture is more vertical. So this is a paper which is published on the update of the Powell's classification. So you can see that all type 3 fractures, they generally say that a significant amount of varus force is involved and there is a fracture displacement. So you need to address the varus component of it. And many authors, these are the recommendations from various authors. From Saglam in 2014, his choice is to use a sliding hip screw. And Basso, he has advised to use a lateral locking plate with 3 screws. And Samsami in 2015, he has also advised a DHS with derotation screw. And various authors, they prefer generally using a double implant. So we did a study in our hospital, it is a retrospective study from 2011 to 2016. The total of 31 cases of ipsilateral neck and shaft femur were analyzed. So nearly 27 cases, we were very successful in treating with a single implant. And only in 4 cases, we had to use a double implant when the neck neck fracture is more vertical or it is comminuted. So this is our results. We had an average follow of 26.4 months. The femur fractures, almost all of them united, but 4 of them had a delayed union. That is because of the comminution, which we did bone grafting. And the femur neck, we had 1 case of avascular necrosis, where rest all united. And Harris hip score, it was excellent in 21 cases, and it was good in 4 cases, fair to poor in 6 cases. So our choice of my take-home message is that whenever you are dealing with the ipsilateral neck and shaft femur fractures, you analyze the severity of the neck fracture. If the neck is minimally displaced or it's less comminuted, then you think of a single implant. If the fracture is more displaced, neck is more displaced, neck is more vertical, then you may think it's ideal to use a double implant. Yeah, thank you very much.
Thank you, Arun. It was correctly told, and then very short presentation that you made. Thank you. Carl, unmute, unmute.
Okay. So yes, we probably do it in the same way. So if it's completely undisplaced fractures, and those fractures very often you only see with the CT scan. So we know that probably 7% of all the shaft fractures, they have got additional also neck or femur fracture. And what we have got routinely, so if it's a high energy trauma with a femoral shaft fracture, we always run a CT scan of the pelvis to see if there's an undisplaced neck or femur fracture. And then we go as well with the recon nail. But most often we use a double implant. At this stage, I wasn't able to use the FNS in combination with a retrograde nail yet. But yes, I think I handle those fractures mostly with 2 implants, because I think the more complicated is a neck fracture. And I think if you have got a non-union in the shaft, I think I can deal with that. But if I've got a complication at the level of the neck, I think that's much more difficult to achieve. I completely agree. Every displaced neck femur fracture, I start first proximally, and then I use the DHS or whatever it's available and then I fix the shaft. So 90% we use 2 implants.
Yeah, many times it is the shaft that is a primary fracture, because often you see that they are comminuted, so they have more violence. So it is neck seems to be a secondary fracture where it is generally falls into position moment you give a traction. In all cases where you don't get a close reduction, one moment you put them in traction, I think we must treat by double implant. Whereas those by you get a straight away, you get a good reduction by traction or by closed method, I think we can go ahead to do a single implant. That is the way we deal it here.
See, even if in close reduction, even if you achieve a needle anatomical reduction, you see with the PFNA, you cannot really apply any interfragmentary compression, can you? So, and even if it's reduced, I would love to have a little bit of compression perpendicular to the fracture site, than just taking the traction off, because when you take the traction off, you always have got a little bit of a shear force. So even if it's displaced, I always go for 2 implants, even if I could reduce it closed and have a near anatomical reduction. So I don't see why I should take the risk of a secondary displacement, or if I've got a non-union at the shaft side, if I maybe have to change the nail, or if there's an infection of the whole thing, then I have to take everything out. The neck is maybe not, the neck fracture hasn't healed by then. So I prefer 2 implants over 1, even if I could reduce it close on the traction.
But clinically, we also observed that if it is done with AFN, it still goes on to heal well. So not that every femoral neck needs a compression.
No, that's right. So you've got experience with 1 implant. The tendency a little bit in Europe is probably more to go for 2 implants. So fix first 1 and then go for the second with the retrograde nail. Yep.
So I'll just end up with a small note. Oops. Yeah. So this is a patient who is a young man, 43-year-old. He has, when he arrived, it was a hemoglobin of 8.4 and lactate was normal. He came with the injury with chest as well as both hip joints being involved. So you can see that one side, that is the right side, is dislocated as well, along with the proximal femur fracture. On the left side, there is typical lateral wall. If you draw the lines, it is exactly the lateral wall that is taken off. And he had a rib fracture, and it was actually like the chest part of it settled soon. And then it is mainly like a bilateral trochanter where we are dealing with a mild pulmonary contusion with rib fractures. So in this, many of the times we also feel that when there is a bilateral femur with chest injury, it is a grave risk for fat embolism. Same precautions we'll have to take it here also. And then with the same amount of precautions, once the patient got stabilized, I think 3rd day or 4th day, we thought having it done. But because of the dislocation, we thought it is a real emergency to go ahead. So Carl, what is your plan would be like now that chest is reasonably all right? So though it's a rib with contusion, so it is both hips. So what will be your take?
I would, of course, I would need a CT scan, and I'm probably more concerned going the right side and the left side. The right side, I'm not sure if there's not a pipkin fracture, even the posterior wall fracture involved as well. So
there is intrafoveal fragment is broken. I will show the CT.
Okay, so it's intrafoveal. Okay, yeah. The posterior wall is intact.
So there is there was a small section which I think this you can see there is one small fragment that is lying in there, but that section is not properly as come. So this is a 3D. So there is a small infrafoveal fragment, not a big one. So nothing to cause concern as far as that is concerned. So
if the anesthetist tells me that I could go ahead, so I would probably try to reduce the right hip in a closed manner. So I would probably use supine position of the legs. Then I would use a shunt pin in order to try to reduce the right femoral head closed. So that would be probably the first step. And then if I can reduce it close, perfect. And if not, then I might have to consider to do a posterior approach if you can't really close fix it, reduce it closed. When I'm doing the right hip dorsal approach, I would need the patient in a lateral position. So the problem would then be the left femur. So in this case, if I can do if the patient is stable, I will probably go ahead first with the left femur, as I said. So if I need a posterior approach, I would fix first the left femur. And with the left femur, I think I can probably get along with the nail. So I will probably put the patient on a traction table, reduce it as good as I can, maybe collinear clamp medially, and then use a TFNA. And then the lateral wall fragment, I think it will fall in place. Then once the left side is done, I could probably put the patient in the lateral position and then do a posterior approach on the right side, reduce it closely, and then you have got an open fracture because you see you've got a large posterior medial fragment which can be locked in. And then on the right side, I will probably would use in a lateral position, I probably would use an upside down list plate on the right side. So
the anesthetist said you have to stage it because he said we can't do both together. So
okay, so it has to be staged. Oh, so if possible, I would do it together. But if not, if it's staged, then the first priority has got the right hip for the reduction because otherwise there's a high risk that for an AVN of the femoral head. So yes,
with this fracture, if you position them in a lateral position, is there a worry?
Yeah, that's why I said before I do the right hip through a posterior approach, you have to fix the left side first.
So if you don't fix it, what will be the concern?
I think you probably have got, if you just put it on the lateral side, I would be worried about a massive soft tissue damage on the left side, even a further displacement. I think the head remains in place, but I would be worried that the shaft maybe is going to perforate all the soft tissue. So I'm a little bit concerned of just.
Anyway, we were also a little concerned and worried, but there was no option but to go ahead with the right side first because it is a dislocated side.
Yep.
So exactly the same plan that you said, we also went ahead. So what we did was like we first got it reduced and then we did an extended lateral approach. Like once it is like laterally, it goes on to little posterior and then the lateral position. And then we did that both. Once we saw the joint, and then the small fragment was removed. The infrafoveal fragment was removed, and then with same like a shank screw, we could get it reduced. Moment we pulled it, it came back to position, and then we got this all these the extensions of this femoral neck. We locked into this distal portion, and then the trochanter portion that was broken, we wired it, looped it, and then once the two interfragmentary screws were passed, then we neutralized it with a distal femur, opposite side distal femur plate. So same thing that you also thought about. So this is what we did. And then on the other side, because I did this here, I I also wanted to do the same on the opposite side. I didn't want to change the implant. So here what I did was not only that, because it's a combination and we're exposing on the same side, I put a small peg of a tricortical iliac crest graft also, and then fixed it, similar fixation. And then it went on 9 months, it went on to heal like this. And then it is at 4 years, both of them healed well. And then he is walking well without, and then he has gone back to his normal activities. This is at 4 years. And he's just like he's a shop owner and then goes and comes back. So
develop on the right side a little bit of an avian, just if you go to back the slide.
yeah, there is a small change. So, but he has not complained of any pain at that stage when he came here. So, though there is increased sclerosis, suspected avian, because that is a dislocated side as well. So we were also expecting some avian might come in, but at 4 years there is no pain. So generally, like trochanters, we always talk about a nail or a plate. And then like Evo also came out with the proximal femur plate. Why did that proximal femur plate fail?
I think it was two reasons. So we had two kind of failures. One was a plate breakage, and the other complication we had a backing out of the screw. And what we found is in some biomechanical testing, what we did afterwards, just by loading it naturally and applying some torque, that you really force the head always in this direction, that the screw back down. And I think that was we really see where the problem was. And the other thing is that the plate, the proximal lateral femur locking plate, was just too weak, I have to say. I think, you see, the same thing, they come up with the new plate, this lateral femur condyle VA LTP, and we have got the lovely distal femur LTP, or the LIS plate. You see, you never had such a strong plate, and I'm sure you haven't seen too many cases with a broken LIS plate or a distal femur LTP. So you see, this new plate, this VA technique, I don't really see the need for the distal femur. Of course, they argue you can place the screw a little bit more in dense bone, you can bypass the stem or whatever. But we have seen lately, and even the report in the JOT from last year, that there are cases where the plate breaks because of the design of the screw hole for the VA technology. So I think one of the strongest, the best plate is still the LIS plate. So even for the proximal femur, if it's off-label use, and you're aware that it's off-label use, if you use the femur upside down on the other side. But I think you haven't seen those complications with the old plate, which were stronger than with the new plates. And the same thing is for the proximal femur LTP. This plate is off the market, and it's never getting back onto the market again. So I think at this stage, there's no the plan that maybe to modify maybe the LIS plate for the proximal femur a little bit with a different shape. So there are some projects running there. But I think one of the big benefits, I think they're coming out next year, is the new modular periprosthetic fracture system.
New?
So we're designing a new modular plate system for the whole femur. So we have got 3 modular plates, distal, middle, and proximal, and you can interconnect them. So maybe part of this system might also be usable for simple fracture fixation, not just for periprosthetic, but also for fracture fixation.
So you pointed out that in this last patient that reverse, that is a distal femur plate can be used. How often you have used this plate for the proximal femur?
Oh, maybe 20 to 30 times.
So what type of fracture configuration you immediately think about this?
I think if I've got a big lateral greater trochanter fragment, which I want to buttress as well. And if I think a nail is not really sufficient to hold everything in place, so really the indication where I think an upside down display might help. And I learned this technique from Professor O from South Korea, who has got a large experience using this case, this technique. And it's mainly I used to make the nail together with the tension bend technique, that's right. But from time to time, I'm still using a femoral plate upside down. And also especially if I have got some significant subtrochanteric fracture, where I don't think with the nail I get enough compression, or that I even can do a little bit of valgization, I think then the play can be very helpful.
So we have nearly done all the presentations, and any questions there, Radhan Shekhar, we can take those questions.
So one question is, how do you select the implant for the proximal femur fractures? You've shown so many implants. So which fracture, which implant to use?
So like we know that proximal femur trochanter, if you take, you have to definitely define them as the stable and unstable fractures. So stable fractures where it is like A1 type or up to A22 type of fractures, probably you can go ahead to do a DHS also. But in many centers, if you want to use a single implant as an inventory, so it is the nail will become the choice. Because we have seen with the DHS, there is a lot of lateral wall breakage also happens. So in our series, we have seen that it is 19.4. That means nearly 1 in 5 breaks. That is why we have completely changed over to nail. So it is now, the nail is the best choice. But there is no harm in using a DHS in a very stable fracture. When the lateral wall is thick, you can still go ahead to use a DHS. That is how you use all unstable fractures. Nailing is the better option. So if it is even when it is a trochanter and then the subtrochanter region, suppose if it is more like a subtrochanter and then it is very high, then you can think of this distal femur plate being used on the top. So that is how we change our implants. Carl, your opinion, Carl?
I completely agree. So hardly ever we use a DHS anymore. So we've got a complete shift in Europe. Either you use the nail or you use, in the meantime, the FNS. But the DHS cell itself, I think it's nearly off the market. So it has been used very seldomly. So in very special type, upside down wrist plate or the nail. So that's probably more. And yes, I think I take your point, TD. If it's a very stable fracture and A11 or maybe 1.2, maybe you can consider DHS. But you see, at the end of the day, I think the nail might be a little bit more expensive. But I think the failure rate is significantly less, especially you don't have the risk really of this lateral wall fracture. So we tend completely towards the nail in those kind of fractures. The proximal.
And also convenience to have a single inventory. So single inventory is.
Ramesh, you told about zoledronic acid. So when do you use teriparatide?
The biphosphonates are anti-resorptives, and terifrac is an anabolic bone-forming drugs. So when a patient is in severe osteoporosis like -3 or -3.5, you can start teriparatide straight away because of the cost factors. If you take teriparatide test given at least for 2 years, so cost for each month will be around 6,000 rupees in Indian scenario. But probably a year it takes 70,000. It takes 1.5 lakhs for the full course to complete. So at least it has to be given for a 2 years period. But our patients, most of the time, 3 months or 6 months, the dropout rates are very high. That's why zoledronic acid is an annual injection, so that you can give one injection and then you can repeat it next year. So the indication for pterifractus, yes, it can be used in osteoporosis, but it has to be a cost constraint and also it has to be given for 2 years time. No point in giving 6 months time and then backing out.
Okay, thank you. And denosumab, you use it for renal failure patient. That's the indication.
Yes, sir.
Score is less than 3 and you want to use
Yes.
that 6 monthly injection.
6 monthly injections. It should also be at least given for 2 years time, so that by 2 years time you can check your BMD and you can look for the increase in the BMD.
Thanks, Ramesh. Anything else you want to discuss? Conclude the session.
If there are no questions, we will say thank you. Thank you, Carl, for coming over and joining us. So it is pleasure to have you. And we missed you coming over here last year because of this. We had to meet in June, so unfortunately we couldn't meet. We missed your bubbly enthusiasm to be around us. Thank you, Carl. Thank you.
Thank you very much, everybody, for your great presentations. And I always learn something. And I'm looking forward to see your first FNS cases.
Thank you. We will send a report. Yes.
Okay. You take care, everybody. Have a nice week. Thank you. Bye-bye.
We'll end the meeting.
Thank you.